So, greetings. I am Farrah Mateen, and I'm presenting on bringing EEG to vulnerable populations with epilepsy. And I'm very excited to present some motivation and some early data that we have on a smartphone-based electroencephalography with a overall goal to bring epilepsy diagnostics to low-resource populations. And I'm currently on faculty at Massachusetts General Hospital, but the work that I'm going to show you is work that is performed in the low-income country of Bhutan. So to frame the issue, epilepsy is the tendency to recurrent unprovoked seizures. And this is a very common disorder that occurs and presents across the lifespan, anywhere from the time of birth all the way to older age. And epilepsy occurs in at least 1% of the world's population in low-income countries. Some people have even estimated up to 2% of the population has epilepsy. And the majority of people with epilepsy live in low and middle income countries. And it is exactly in these same locations where epilepsy diagnosis and treatment is the hardest to achieve. And there's several reasons for that. One of them is a lack of appropriate diagnostic tests. Another is a lack of appropriate treatments. And really the expertise is a linking factor between someone with epilepsy and getting them to the right treatment. There are many reasons to believe that epilepsy is actually only going to increase with time, increased number of preterm births as people age. Globally, higher numbers of people with stroke and head trauma as we continue to industrialize and have more motor vehicles of various sorts on the roads. Importantly, epilepsy is very treatable. Approximately 2/3 or even up to 75% are treated with a single anti-epileptic drug. Approximately 15 to 20% are treatable with 2 anti-epileptic drugs. And these can be as cheap as 3 cents per pill, which is very affordable for people in low-income countries in most circumstances. So linking people with epilepsy to treatment is the critical issue. And the motivation statement here is that there is a critical need for a portable real-time EEG device that can be incorporated into routine initial diagnosis and care of people with suspected seizure disorders. So it's not practical that neurologists, which is the expert in this condition, will be found everywhere in rural and remote settings or in low-income settings. So we need to be able to equip the frontline healthcare workers, whoever they are, with their training, with appropriate knowledge, and in the correct circumstances with the right technologies. So although this is really important for resource limited settings, I might add that this is not exclusively needed in resource limited settings. There are particular places throughout North America that would benefit from low cost diagnostics as well. And potentially one day patients could even be able to self-diagnose with a EEG that is low cost and can be put in the mail and recording EEG or brain waves. So as many of you already know, the brain is electric. It creates electrical impulses. And when there's a certain electrical storm, if you will, that can create a clinical event, which is a seizure. So EEGs are really meant to look at brainwave patterns. They don't necessarily diagnose seizures, which are clinical events that can help, but EEG is really looking interictally between episodes. So importantly and interestingly, the EEG low-cost devices really had a lot of heritage in the video gaming world, where people were very interested in their frontal lobes and their planning and their ability to see if their gaming changed based on their EEG waves. So the original sort of low-cost EEG devices for home were really not designed for epilepsy per se. In many cases, they're designed for recreation. And with my collaborators, I became aware that some of these fun and optional EEG ideas could really be repurposed for a more clinical and necessary issue, which is epilepsy. So to make a relatively long story short, I'm going to tell you about the Bhutan Epilepsy Project. So this is a tablet that I was holding that shows basically what a low-cost EEG device can possibly do. This is one of our participants in Bhutan. You can see here that there is a spandex cap, almost like a shower cap, that has 14 pre-placed leads. And that those leads can basically create a signal that can be read on a regular Android tablet. And importantly, these hats have the leads so that you don't need to know a lot about the brain or where to place the leads. You just need to be able to Velcro the hat underneath the chin, and the hats are replaceable, and they're different sized hats for different head sizes. And we've used EEG Cap here, but there are other options as well. And the app was developed by my colleagues and close collaborators at the Danish Technical University in Copenhagen. We've clinically validated this idea over time. This is one of our study staff members at the time placing the hat in a Bhutanese child. And you can see here the app in progress. So again, these are connected through Bluetooth. You don't have to have the tablet hanging off of the hat, and they should just be in close proximity. For those of you who are interested, this is from one of our manuscripts that shows where a traditional EEG lead placement would be, where the EEG Cap EEG lead placements are, and then what the coverage is compared to a standard EEG. And importantly, real EEG leads are made of gold, quite literally, and that can, of course, be very expensive. And real EEG machines, if you will, are very expensive. They're probably 20 to 30,000 US dollars, whereas a smartphone or a tablet is, in the sort of hundreds of dollars of range, depending on your tablet, can be quite inexpensive. And the EEG Cap can be bought with these sort of proprietary box. We're talking about $250. So there's a margin of decrement that's quite significant. To give you a snapshot of how the EEGs look and are read, we've collaborated with an excellent computer scientist, Mike Shakerman, who has now received his PhD from the University of Waterloo in Canada. And through his platform-based development, we've been able to take the EEG recordings, put them on this open source website, and allow people remotely to read the data. And so we think this is a good way to standardize the data, to bring in experts in an asynchronous way and be able to, as you can see here, score the EEGs based on important clinical variables. So for example, are the leads working? We ask them to rate quality, and we ask them to look at certain features of relevance to epilepsy, like epileptiform discharges. And a lot more could be done. But what this allows us to do is to have a uniform platform for people to read the EEG output. And I mentioned some of these already, but there are several advantages to an EEG smartphone or EEG tablet in a low-income setting. I think some of these will be immediately obvious, but there is no need for electricity, which can be very challenging, first of all, across different locations, and also in low-income settings where electricity is not a guarantee. And sometimes with electrical surges can actually fry really expensive devices. The older story of EEG is a very old technology, but in the past people didn't have enough paper, there wasn't enough ink, there weren't enough technicians. A lot of issues have arisen, and EEGs where they exist, particularly in Africa, often are concentrated in capital cities, which may be far away from where people with epilepsy are most stigmatized and have least access to care. So in a very brief way, I'll just mention the validation study, our first validation study of the smartphone EEG. We've gone on to do a couple others, but this was the first one. So I think it's the one that sort of set the stage for understanding how are we going to validate what turns out to be a fairly old science in terms of EEG, and try to figure out if smartphone EEG is sufficient to replace the old standard. So in order to do that, we wanted to compare certain metrics of value in terms of EEG clinically. The first one we selected was the sort of spike detection or epileptiform discharges. Secondly, there can be many abnormalities that are not epileptiform but are still clinically of relevance potentially. For example, background slowing can be of importance, but is not necessarily an epileptiform discharge. And then number three, what is the composite of those two? So in Bhutan, very briefly, there are no neurologists. It's less than 1 million people. This is in the Himalayas. And there's a lot of epilepsy in Bhutan for reasons that are partly explained and partly still unknown. For example, there's a higher prevalence of neurocysticercosis or tapeworm that causes epilepsy. Also, there potentially are genetic causes of epilepsy, and just like I mentioned at the beginning, increasing rates of non-communicable diseases. Importantly, in Bhutan, their public healthcare system, anti-epileptic drugs are free out of pocket to patients. So our study population, just as a brief overview, 71% had a seizure in the prior year. So it's a very active epilepsy cohort. Approximately 70% had loss of consciousness or generalized seizures. Neurocysticercosis prevalence was up to a quarter of our patients. And it's a young population, about 24 years of age, but spanned the entire lifespan. And these are treated patients with anti-epileptic drugs. These are two examples of a smartphone-based EEG reading output for those of you who are interested. So these are examples of types of patterns that could be clinically relevant. So abnormal bilateral paracentral spike and wave pattern. And then on the bottom panel, abnormal diffuse runs of 3 Hz spike and wave discharges. So these have importance in terms of characterizing the epileptiform pattern and therefore potentially the clinical syndrome in the right circumstances. These are 2 different tracings but show similar findings. So you can see in a quote real EEG or traditional XL tech, this is a certain pattern that you can recognize. And we think that the smartphone EEG does pretty well in also recognizing a similar pattern. So even in spite of the reduced lead system, you can still see clinically patterns of interest. Our study included 205 children and adults, all comers that had to have at least 1 seizure. And these EEGs were read extensively by experts, by adult and pediatric, as appropriate, epileptologists. And we asked people to read the smartphone and the standard EEGs of the 205 participants. The gold standard, the standard EEG was read twice, and the smartphone EEG was read once. And any discrepancies, for example, somebody said it was normal and the second person said it was abnormal, were resolved through a third adjudicator. Just for the background prevalence of abnormalities, approximately 25% had epileptiform discharges. And this is a summary slide of a relatively time-consuming process. It shows that the sensitivity for any abnormality is about 53%, specificity 84%. For epileptiform discharges, sensitivity was 39% and specificity 95%. And the other parameters are also listed here. So in summary of this original study, a low to moderate sensitivity was found, but a high specificity was found. So what we really wanted was a high sensitivity, and a high specificity would also be good, but high sensitivity is really good for screening. What we found instead was this is potentially a better confirmatory device. So that means more work is yet to be done. And so I'll just mention some of the things that have happened since this study and are ongoing. So 14 leads is very few compared to 28, which is a standard. So we're looking at increasing the number of leads. Also, the headset probably could be continued to be refined in terms of connectivity. Right now, this is not useful for iOS, it's only for Android, but a lot of people, of course, do have other operating systems. There is a potential for AI or automated intelligence for reading the EEG, even in terms of quality at the point of care. So that's our next step. And we think that this has application not just to people with epilepsy, but also in neonatal encephalopathies or ICUs and other potentially similar indications. So For those of you who are interested, we published this study in Bhutan, but we've also published 2 follow-up validation studies, which I didn't talk about today, in the Republic of Guinea and West Africa. So also very active epilepsy population, different needs, and different populations, showing that the smartphone EEG has similar characteristics, and things have been iterated over time. And for more information, my website for my research group is here, and my email is also on that website. And I'd just like to acknowledge, as you can see here, this is work of many dozens of people over many years. And even though I can't name each one of them, the amount of effort that has gone by technicians, by my Bhutanese colleagues, my African colleagues, students, residents, and fellows has been tremendous. And of course, by our participants who have been very patient and very engaged in using technology in a way that hopefully will one day benefit future participants. So thank you very much for your time, and hopefully you enjoy the symposium.